All right, thank you for filling out that poll for us. Just in case there was any who had concern, that's completely anonymous. That won't be linked to you in any way. Thanks for joining us. We hope this is pretty informal. You should know we're all a little bit new at doing Zoom seminars like this. So if we seem a little stilted, that's just because we are a little stilted. We have a great team here. We've been wanting to do this for probably a year now. We've been talking about it. So we're glad we're finally getting a chance to do this. And hopefully we answer some of your questions and address some of your concerns and maybe help you make a little bit of personal decision about how to move forward with whatever you're struggling with. I'd like to introduce our team just a little bit so you have an idea of who we are. My name is Brandon Reynolds. I'm a urologist. I did my training at the University of Iowa, both medical school and residency, and I've been in practice about 15 years. I've moved here just 2.5 years ago, and absolutely love being up here in the Northwoods and being in Minnesota. My partner, Dr. Matthew Watson. Hi. Hopefully you can see him, right? Yeah. So Dr. Watson did his his medical school training at Michigan State University, and then did his residency in urology at the University of Tennessee at Chattanooga. He's originally from the Upper Peninsula, so coming back to the Northwoods here is coming home for him, and we're really happy to have him with us, and it makes it possible for us to do really expand the services that we want to be able to offer here. So it's good to have Matt with us. Emily Hilgers, hi, next to me here. Emily Hilgers did her undergrad at Bemidji State University, where she also played basketball, by the way, so don't try to dunk on her. You'll lose for sure. She also did her doctorate of nursing practice at the St. Scholastica, and basically joined us here when I came. We kind of came at the same time, so it's been a great 2 years. Monica Larson. Hello. Are you guys seeing her? Okay. Monica did opposite of Emily. She went to undergrad at St. Scholastica, and then went to the University of North Dakota for her nurse practitioner degree. And she plays wicked volleyball, so don't challenge her on that. And finally, I just want you to know Lindsay Turner back here. Hello. And Courtney Applequist. They're our sponsors from MEDTRONIC. And if you pursue therapy with us and we're able to help you, there's a good chance you will actually get to know Lindsay fairly well. She's essentially part of our team. And so it's really good to have them with us and help us figure out how to do a Zoom meeting. Okay, enough introduction. So let's talk about what brings us here today. I'm going to turn the stage over here to Monica to talk a little bit about the problems you might be having.
Thank you, Dr. Reynolds. We are hosting this because so many people have bladder or bowel control issues. More than 50% of people with incontinence haven't even discussed it with a doctor. Many of you might be having these thoughts, feeling concerned, exhausted, or overwhelmed, and maybe you don't want to go anywhere because of your bladder or bowel control issues. And that can be embarrassing to talk about. We are here to change that, and we are here to help. Next slide. Living without limits. On the agenda tonight, we will talk about understanding bladder or bowel control, how it works, and some of the problems that can occur. Next, we'll talk about the care pathway, which shows the possible progression of treatment. Then we'll talk about treatment options in greater detail on the many ways to treat bladder or bowel control issues. And towards the end, we'll have a special focus on the MEDTRONIC INTERSTIM systems and the MEDTRONIC neuro system. And at the very end, we'll wrap it up by answering your questions. So we want you to know that you are not alone. Overactive bladder and fecal incontinence are extremely common. 1 in 6 adults has overactive bladder, and that's about 37 million Americans. 1 in 12 adults has fecal incontinence, and that's about 20 million Americans. You may be asking, if it's so common, why haven't I heard about it until now? Well, many people with overactive bladder and fecal incontinence self-manage by wearing pads or restricting their social outings or activities. Bowel or bladder control issues can happen to women and men of any ages. And although your risk increases as you get older, that doesn't make it a normal part of aging. Next, what is normal and what isn't? It really is important to note that incontinence is not a normal part of aging or something you just have to live with. It's a serious health problem. It may prevent you from going places or doing things that you like, fearful of an accident, always looking for that next restroom, making frequent trips to the restroom throughout the day. But bottom line, overactive bladder and fecal incontinence can be very embarrassing conditions, and they have a significant impact on your quality of life. And now I'll turn it over to Dr. Reynolds.
Okay, so I love what Monica emphasized there about patients not wanting to bring it up. I've had so many patients over the years say, well, it's just part of getting older, so I'm just living with it. Isn't that just how things go? And I don't know, some women especially are they just tolerate it and just live with it and don't bring it up. And what we can do for it is relatively easy. And so we really want people to seek care. So let's understand just a little bit about how bladder control works. Your bladder is a muscle. It's a muscle shaped into a bag, and it empties by contracting, but it's not going to contract unless it gets a certain signal to do so. So as your bladder fills with urine and gets about half full, signals from stretch receptors in the wall of the bladder start sending signals up to your brain. And those signals shouldn't start anything. They're just signals that, hey, I'm starting to get full. And as you get more and more full, the signals get more intense and maybe even border on discomfort and pain. Normally, the bladder stays relaxed until you are in the bathroom and your brain consciously tells yourself, I'm going to go to the bathroom now. And a signal comes back from your brain to the bladder, you relax, your bladder squeezes, and you empty. That's normal bladder physiology. Anything different from that is abnormal physiology, and we'll hear from Dr. Watson about that in just a minute. So let's go next. So bowel works very much the same. So the very bottom part of your intestine, as you'll see on the slide there, kind of functions like a bladder. As food moves through your intestine and accumulates right at the bottom of your bowel in the rectum, that rectum starts stretching just like a bladder does when it's full. And as it stretches, stretch receptors tell the brain, hey, I'm starting to get full. Maybe you should go to the bathroom. But that rectum should not do anything until your brain tells it, hey, I'm on a toilet and it's now socially appropriate, and it contracts and you're able to eliminate. If that process happens in any other order or without your brain control, there's a problem. If that message from the brain doesn't come back appropriately and you don't empty normally, that's the opposite end of the control problem. And we'll talk about that a little bit as well. Let's see, I'm getting behind on my own slide. Okay, what causes incontinence? Well, all kinds of things can lead to it. Sure, daily habits, things you eat and drink, medications you take, an inability to get where you need to go quickly enough can cause it. Certainly, multiple pregnancies, childbirth, radiation, pelvic floor trauma, spinal cord trauma, brain trauma, surgeries that you may have had. All of these can precipitate problems with incontinence and can be addressed. So the main forms of incontinence, let's go to the next page. Stress incontinence, number one. Number three, overactive bladder, which includes urge incontinence. And then two in the middle, urinary retention, where you're unable to urinate. So I'm going to go ahead and turn it over to Dr. Watson to talk a little bit more about the pathophysiology of these problems.
Thank you, Dr. Reynolds. So let's talk a little bit about stress urinary incontinence. So this is any process that causes leakage of urine as you increase the intra-abdominal pressure. That's loss of urine with coughing, sneezing, laughing, getting from a sitting to standing position, running or jogging, anything that causes that increased intra-abdominal pressure that gets transmitted through the bladder, usually due to an incompetent sphincter causing leakage, is considered stress urinary incontinence. Since this is a sphincter abnormality, it usually requires surgical intervention to correct this. There is one medication that you can take orally for mild stress urinary incontinence, but for the most part, we're looking at a surgical intervention to treat this type of coughing, sneezing, laughing urinary incontinence. Next slide. Urinary retention. This is not fully emptying your bladder. So like Dr. Reynolds mentioned, the bladder is a muscular bag that fills and empties, and that's its normal function. If the bladder is filling but not completely emptying, then this is considered urinary retention. We diagnose this in the office with a post-void residual or an after urination scan that looks at the amount that's left in your bladder. If you're not emptying your bladder, this can cause infections and eventually can actually cause pressures that back up and can hurt your kidneys over the long term. Next slide. What is overactive bladder? So overactive bladder, like Dr. Reynolds discussed, is having an urge to urinate that you cannot suppress, and that can cause urge incontinence where you actually leak urine because of that urge that you're unable to suppress. Overactive bladder is urinary frequency greater than 5 times in a day. So if you're going all the time, you're searching for a bathroom, as soon as you enter a restaurant, for instance, because you know that you're going to be hit by this urge, those are all signs of overactive bladder, and things can be done to help you with that. And then finally, we're going to talk a little bit about fecal incontinence. This is leakage of bowel contents. There's 2 types: urge incontinence, similar to urge incontinence with urine. This is an inability to resist the urge to go, but concerning your bowels. And then passive incontinence, where you just have the inability to feel that you need to go, and so then you leak stool. And we also provide treatments for this. And we'll have Emily talk a little bit about some treatment modalities for dealing with these types of issues.
Thanks, Dr. Watson. So the good news is treatment is possible with these symptoms. So when you first come to see us in the clinic, you could see any 4 of us, and we'll start out by discussing your symptoms. We'll ask you about your urgency, maybe frequency, emptying your bladder. We may want to do further studies such as post-void residuals, urocuffs, urodynamic studies, cystoscopies, or bladder diaries. This is especially the case if you're a male patient, because we may want to rule out enlarged prostate. After that, we will guide your treatment using a patient care pathway, and these will range from conservative treatments to advanced therapies. Most of the time, we start with lifestyle changes, and this is the conservative therapy route, where most patients will change their behaviors. This includes changing the foods and beverages that they consume, for example, by decreasing caffeine that can reduce your urgency and frequency. Sometimes we may recommend physical therapy to help strengthen your pelvic floor. We may recommend exercise, time toileting, such as urinating on a schedule. By the time we see most of our patients, they have been doing these on their own already. The next step in the patient care pathway is oral medications, and these are in 2 different classes. Some examples of these medications are oxybutynin, Detrol, Gemtesa, and Myrbetriq. These medications require daily intake, and they can cause side effects such as dry mouth, constipation, urinary retention, possible memory issues, or hypertension. Some patients will stop these medications due to these side effects, the possible cost of taking them, the effectiveness, or the burden of taking a daily medication. So next we will discuss advanced therapies and other options. So I'll hand it back over to Dr. Watson.
So advanced therapies are any 3rd-line therapies. So that's anything that doesn't include lifestyle modifications and oral medications. So this is kind of looking at more intervention that's not pharmacologic, taken orally. Next slide. So one treatment for overactive bladder is Botox. So this is the same type of Botox that you get injected into your face for wrinkles. It does the similar thing to the muscle of the bladder, which is paralyze that using an endotoxin. This is a procedure that can be done in the office or in the operating room. We go in with a scope and we inject the bladder anywhere between 10 and 20 times. And it paralyzed that muscle. Therefore, you're not having that kind of spasming of the bladder muscle that can cause overactive bladder. The pros of this treatment are you're not getting something or a device implanted. Cons to it, infections. It's not a permanent treatment option. So you usually have to come in every 3 to 6 months to have re-injections. That can cause distress to patients. And additionally, 1 in 9 patients can have urinary retention, requiring self-catheterization, and that can be distressing to patients as well. Next slide. Second type of therapy for overactive bladder is posterior tibial nerve monitoring, or PTNM. This is a treatment modality where you come into the office for 12 weeks and we stimulate the tibial nerve. The nerve roots to the tibial nerve are L4 to S3. The S3 nerve root helps modulate the bladder. And so by us stimulating this tibial nerve, we're hitting that S3 nerve root, and therefore decreases can decrease the urinary frequency that you may have with overactive bladder. Pros to this is it's completely non-invasive, or relatively completely non-invasive. Cons to it, you've got to come to the office for 12 weeks and then monthly thereafter, and so it can be very time consuming to actually, not only get the initial treatment, but then continue with maintenance. Next slide. And now Dr. Reynolds will talk about the MEDTRONIC INTERSTIM system.
Okay, so before we talk about INTERSTIM, let's just all take a little break and think back about what we've heard. You come into the office and you're going to see Emily, or you're going to see Monica, or you might see Dr. Watson or myself, and have an evaluation and figure out what your symptoms are, what's bothering you the most. Are you emptying? Are you not emptying? How frequent are you? How well does your urine come out? Does it not come out well at all? Are you obstructed, or are you the opposite of obstructed? And as we establish all of that, this care pathway that Emily first mentioned and that we've been talking about gets initiated, and you might take medications. Like Emily said, you may have already taken medications and be past that line. If you're past the line of medications, you may go on to these advanced therapies that Dr. Watson was talking about. The first one may be chemodenervation or Botox, like he mentioned. Easy to do, works well for the right patients, doesn't work the best for other patients. And as he mentioned, you will be in to see us a couple of times a year to get that boosted. Great option for a lot of patients. Second option he mentioned, peripheral tibial nerve stimulation. Great option for a lot of patients, but again, a lot of time commitment, and you will be coming in to see us. Again, we are happy to do it, and it does great for the right patient. The final option, sacral neuromodulation, is kind of the king of the hill when it comes to advanced therapies. And it's king of the hill probably mostly because it has the highest success rate and also the lowest side effect profile overall. So sacral neuromodulation works just like peripheral nerve stimulation that Dr. Watson talked about by interacting with the nerves that talk with the bladder. So you remember when we talked about bladder physiology, we talked about how as the bladder stretches, it sends a signal to the brain. The brain needs to send a signal back to get the bladder to squeeze. It's a little more complex than that, though. There's actually a reflex in your spinal cord that is there when you're an infant that's supposed to go to sleep. Sometimes that wakes up and starts sending abnormal or aberrant signals to your bladder. Sometimes the signal coming from your brain doesn't get all the way through and the bladder doesn't squeeze completely. So the idea behind sacral neuromodulation is we're going to get that nerve pathway from brain to bladder to work normally. Signals from bladder get to the brain, bypass that spinal cord leprechaun that's misbehaving. Signals from brain to bladder get where they're supposed to go, and your bladder is able to behave more normally. The beautiful thing about this treatment is it helps not only the overactive bladder, the urge incontinent patient, it also helps the patient who isn't able to empty their bladder, the patient who has retention That's not from a prostate or obstruction, just their bladder just isn't working like it should. It helps both of those patients equally. It also helps the fecal incontinent patients, the patients who are struggling with losing their stool because their rectum is overactive or possibly underactive. Did I hit everything on that slide? Okay, so let's talk about say yes to the test. So the other nice thing about sacral neuromodulation is we do have to test you first. We don't just throw this device in and now you've got something in whether it works or not. We get to test your nerves first. So the first thing we do, if we decide together with you after talking things through and figuring out what your problem is, if we decide this is the right thing to do, we do a test where under some sedation, we put temporary tiny little leads through tiny little needles into the nerves on either side. Those are connected to a small battery that you wear discreetly outside the body for 1 week. Sometimes a little less than that, sometimes a little more than that, roughly a week, and see if it's working. If it doesn't work, no problem. Those leads come out painlessly in the office. If it does work, then you're confident moving forward having the final implant. The final implant is actually a lot easier too than you might think. Often that can also be done under sedation if patients prefer, or under anesthesia. The procedure itself is quick, usually 30 minutes. And the lead that stimulates the nerve is placed and it's connected to a little battery. Some of our batteries are rechargeable, some of them are permanent. They can last as anywhere from 10 to 15 years and sometimes more, depending on the patient. See, I'm going off script now, so I have to look back at what I'm supposed to be saying here. 89% of people using the MEDTRONIC system for their bowels or fecal incontinence have long-term success, and 76% of people have success with bladder control. Now that's on nationwide databases. And I would say in our office, we're very invested in finding the right treatment for each person. So when you come in, it's not going to be oh, everyone gets INTERSTIM or everyone gets this first or second. We have every tool available for overactive bladder, urge incontinence that is on the market. Everything that people are offering, we are offering. And so we really want to tailor it to your problem. So we would like to think that our numbers are higher than 76% with INTERSTIM. And I think my experience with my own patients has been it is higher than that. And I think that's because we do try to make sure we fit you with all the treatments and not just give the one that we like the most or anything like that. How long has this been around? You might ask. Chemodenervation or the Botox is actually one of the newer kids on the block. I started doing that in my practice probably 10 years ago, maybe a little less than 10 years ago. INTERSTIM I've been doing since 2004, I think, 2004. And I've been doing it continuously that whole time. It's undergone multiple changes. MEDTRONIC is a company that invested in research, and there is actually more than just the MEDTRONIC system, but we've been doing this for decades now, and it has a proven track record. So I'm very happy with it. I'm very convinced that it is a great option for a lot of patients with overactive bladder and urge incontinence. So the real question is the therapy right for you? Are you a good candidate? And is this going to work? What makes you a good candidate? One, if you have symptoms of overactive bladder, urgency, frequency, looking for bathrooms, can't control your urine, leaking when you're in the produce aisle at Super One, these are all symptoms of overactive bladder. You're a candidate. If you struggle to empty your bladder, you just can't get it empty, especially if it's leading to things like infections. Let us see if you're a good candidate. If you're not obstructive, as Emily mentioned, men with enlarged prostates can sometimes have other issues going on. But if you're not obstructive, your bladder just won't squeeze. Maybe you've had 7 kids. Maybe you've had pelvic surgery. Maybe you've had bowel surgery. All of those can lead to failure to empty your bladder. Let us check you out. You may be a candidate for a solution. If you've tried lifestyle changes, if you've tried pelvic physical therapy, if you've tried oxybutynin, Detrol, and Nablex, and any number of other medications for overactive bladder, you're a candidate. So really, the next step for you is just an evaluation. There are multiple providers that do this. I don't want you to feel like we are the only people in the world that do this. Lots of urologists do this, but we do have a lot of experience with it. And it is a problem we are dedicated to and enjoy taking care of. So I think the next step, let's see, it says on the slide, give us a call. Say you'd like to see us, tell us what your problem is. Emily, Monica, Dr. Watson, and myself have a lot of experience with this. We see patients literally every day with this problem, and we have a lot of patients who are happy. So I think with that, we'll go ahead and turn. Is it question time? Am I done? I'm supposed to be done.
This question done here.
So I don't know if we have any questions that have come through the system. Your question might be about anything we've discussed or things we haven't discussed. I know we didn't talk as much about the neuro system, which, we could address that too, if you have questions about that or Botox or.
So we do have one question. How long does the therapy last?
Good
Guessing.
question.
Battery longevity or
Maybe all.
Well, let's
Yeah.
let's just hit all. So Dr. Watson mentioned with the Botox, that will last anywhere from 3 months to a year. Okay, so I've had patients go a full 12 months with symptom relief, but I've had patients begging me to do it again in 3 months. I would say on average, 4 to 6 is what most patients are doing. And typically after a Botox injection, which we usually do in the office, sometimes in the OR, depending on your particular problem, that first time we don't know how you're going to do. So typically that first time we'll see you back in maybe 3 months, see how you're doing, see if your symptoms are coming back. After 2 or 3 injections, you get into a routine and you'll know, oh, I'm a 4-monther, I'm a 6-monther, I'm a 9-monther. And we'll get into a habit where we just see you when your symptoms start coming back and when we do another injection. So that's Botox, and Botox can last indefinitely as long as you continue to get the injections. The peripheral nerve stimulation, where we stimulate the tibial nerve in your leg, that's a once a week for 12 weeks, and that's usually a once a month maintenance. Sometimes you can go longer than a month maintenance. I have patients who will go every 6 months between maintenance. It works. If it works for you, it works. If it doesn't work, it's not going to work. So it's really a question of, are you willing to invest the time to see if it works, or do you have the patience for that? For some patients for whom surgery may not be an option, that's a good place to start. I will be candid with you right here, and I'm sure my Medtronic reps, I don't know what their experience is, but I will say we struggle to get insurance coverage after 2 years. So after you've been on it and you've been maintenance, insurance stops wanting to cover maintenance therapies. That's just my experience. Take it for what it is. The final option, the INTERSTIM, the battery is the key. Once we get it in good place and it's working, the battery, a permanent battery, will last you 10 years. A rechargeable battery will last you 15 years. And honestly, the company won't tell you longer, but my suspicion is it would last much longer than 15 years, even at that. So when you come in, we kind of show you the different batteries, what the size is, what it would look like. The rechargeable battery needs to be recharged at least every 2-3 weeks. Often once a week is a nice habit to get into. The non-rechargeable literally will sit in your back and work for 10 years. And you will stop seeing us and you will forget that we're here. And 10 years down the road, you'll say, my symptoms are coming back. Oh yeah, I saw that Dr. Reynolds or Dr. Watson, or last time I saw Emily or Monica was 7 years ago. And then you come back and we switch out the battery. And who knows, by 10 years, we may have a thinner, smaller battery that lasts 30 years. The technology is improving all the time. So, but once INTERSTIM is in and working, it typically does not stop working for you. So
We've got about another dozen questions that have come in.
Oh my gosh.
So we'll
Okay.
start,
Yeah.
we'll start
All right.
going. Feel free to answer. So the next one.
Okay, is how does this therapy affect people's lives? What do your patients say?
It improves them. It's when it works like that, and patients love it. And like Dr. Reynolds said, they forget about the symptoms they were having before. It's a real game changer.
Yeah, I would agree with that completely. I've put them in teenagers and I've put them in 80-year-old patients as well, the whole gamut. And the biggest word is life-changing when it comes to INTERSTIM. I think Botox is life-changing too. Any of these treatments that works for you is life-changing. So when you find the treatment that is right for you, whether it's Botox or INTERSTIM or PTNS or even medications, that's life-changing. Do we sometimes have patients that it doesn't respond to? Absolutely. We don't want to make you think that this is 100% successful for everybody, but even patients who see 50% improvement, that's 50% fewer times that you might have a leaking event, or 50% fewer times you might be looking for a bathroom. That's waking up twice a night instead of 4 times a night. You're sleeping longer. So it is a game changer.
And like you had mentioned earlier, we can pinpoint exactly what's going on. And if one treatment doesn't work, we've got the full breadth of treatments available to find the one that does work for you and improve your quality of life.
I think, and kind of to Matt's point, to Dr. Watson's point there, just because you choose one doesn't mean you can't have the other one. There's no burning bridges when it comes to these treatments.
Question, is the therapy typically covered by Medicare?
Yeah.
Mhm.
Absolutely.
Yep.
You bet. Never had a problem.
Is the test painful?
Not usually. I mean, you can have sensations in the perineum or the vagina, but it shouldn't be painful. You may have some pain kind of at the incision sites or at the placement sites, but it's usually very mild and well tolerated by most patients.
I would say in the actual treatment, if you choose to be completely asleep, you can during the test placement. If you choose sedation, which most patients choose, you'll be very comfortable, you'll be very forgetful, and we use lots of local anesthesia. So you usually don't, you kind of a little stick and a burn, but you don't feel us putting those leads in. So I would say painful. I agree with Matt that when the stimulation is going, you can feel a little flutter here and there, but I wouldn't characterize it as painful. We always send you home with pain medicine, but I would say less than 50% of patients use it after the test.
Good. All right, another question. I have had urinary incontinence for several years as part of my perimenopause. I recently heard that vaginal estrogen cream addresses this, but I found it hard to believe. Do you have any information on this?
So, yeah, the intravaginal estrogen cream, topical estrogen cream that can bulk up the vaginal mucosa as well as the urethral mucosa. It's used primarily for recurrent UTIs. It's not actually indicated for stress urinary incontinence. If that's indeed what you have, you'd have to come in. We'd have to have you fill out a questionnaire and really pinpoint that it truly is a stress urinary incontinence issue. But the topical vaginal estrogen, I don't usually prescribe for incontinence alone because it's not indicated and it's not under AUA guidelines.
Yeah, you'd have to have really mild incontinence for that to, I think, really be clinically effective.
Will you talk about stress incontinence a little bit?
Sure, you bet. So stress incontinence, Dr. Watson was talking about how when you cough, sneeze, run, jump, you might leak. So think of the two types of incontinence, stress and urge, as being sphincter or bladder. So in stress incontinence, you have a bladder that fills with urine, and you have a sphincter on the bottom that stops the urine from coming out. If that sphincter isn't working effectively, then any kind of increase in pressure on this bladder filled with urine is going to cause leaking to come out. Okay. In urge incontinence, your sphincter could be as strong as all get out, but the bladder squeezes on its own, and the bladder muscle is so much stronger than the sphincter muscle that with enough squeeze, you lose urine. That's urge incontinence. So in stress incontinence, the bladder's fine. The sphincter is the problem. It's weak. Now, it can be weak for two main reasons. either the sphincter muscle itself is damaged somehow. Maybe you had surgery, maybe it was a really traumatic childbirth and there was a lack of oxygen and blood flow to that sphincter for a time, or maybe the trauma of the childbirth and the repair led to some sphincteric damage, but the sphincter itself just can't squeeze. The other problem with stress incontinence, though, is the sphincter might be just fine, but it rocks out of position. The sphincter is supposed to stay right under that pubic bone and not move and be in line with the rest of the muscles of your pelvic floor. If, on the other hand, through the vicissitudes of life, your sphincter is too mobile, those fascial planes have stretched out, and you cough and sneeze and that sphincter moves out of position, all by its lonesome out there, it may not have the strength to hold the urine in, and that will cause you to leak too. Usually we'll do tests for that. We'll do things like urodynamics, where we look at how much pressure is required for you to leak. If the pressure is really low, often there is sphincter damage. If the pressure is fairly high and we do an exam and we can see you really move, that urethra really moves, it may not be a sphincter problem, maybe just you're too mobile. So typically when we fix stress incontinence, as Dr. Watson mentioned, it's going to be a surgical repair. You may have heard of slings. We put in slings to kind of hold that overly mobile urethra back in place. In really severe cases, we may have to put in stronger types of slings that compress the urethra. Sometimes we have to inject little bulking agents. That's actually the easiest one to do. Bulking agents next to the urethra that kind of bulk it up so the sphincter doesn't have to work so hard to keep that tissue together. And finally, in patients who can't tolerate slings, we want to avoid foreign bodies, or there's been lots of other things, we may actually come from above and secure your bladder from above robotically, what's called a vesical urethropexy. So there's a number of approaches that we can use to address stress incontinence. None of what we have talked about today is for stress. It's all for urgent overactive bladder. But no question, stress incontinence is just as debilitating as urge.
I think that's a great question. Like we had mentioned earlier, it's really important to figure out exactly what type of incontinence you're having, because a treatment for one type will not help the other type. And I've seen patients in the office and they've gotten a treatment for a type of incontinence that they're not having, and they're wondering why it's not working. And it's because it wasn't, the clinician who had done the intervention didn't do a good job of pinpointing exactly what was going on. So that's the key. Anytime you're going to offer an intervention, you've got to have the correct diagnosis to ensure that outcomes are optimized.
And the other thing I would add to that is there is a diagnosis of mixed incontinence. There are patients who have both. They have stress and urge, and that can be frustrating for the patient, and it can be a little dicey for us clinicians in helping you solve that. If you do have mixed incontinence, when we meet with you, we will talk about both, and it will be up to us as providers here to figure out which one to address first. Because for most patients, one is predominant. Either the urge is the biggest problem or the stress is the biggest problem. And sometimes, although the treatments don't treat both, the problems can impact each other. Stress can make urge worse and vice versa. So it could be that you had mixed, someone treated you, and you really just need the second half of your problem addressed. So that's something to keep in mind.
Exactly. There's a question about symptoms specific. She talks about having the urge to go, but really not going a lot, and can't get her pants down and getting up a couple times a night. Would this help her?
Well, kind of like I said before, the diagnosis is the key. So I think that you come in, we may have you fill an avoiding diary, we figure out exactly what's going on, and then based off of that, we could offer treatments. But it sounds like there may be several things going on, and we really want to define specifically.
I would say there's two main reasons that you would have a slow flow or a small amount of urine and yet have urgency and lose it. One would be your bladder's empty, and it just doesn't take very much until you get that urge and you lose it. And so that's why you don't have much and it's so slow. But the other problem that can happen is you're actually very full and you're not emptying, and a little bit comes out, but you're leaving a lot behind. So like Dr. Watson said, until we know, are you leaving a lot behind or are you completely empty? What sort of urgent incontinence are we dealing with? It's hard to know exactly what to do, but the condition you are describing, we have all heard time and time again. Are you a good candidate for treatment? Absolutely. Can a solution be found for you? I can almost guarantee there's something we can do to help you be better.
I know if I was having issues with my urination, I would want to see a urologist who's an expert in the bladder.
Absolutely. Yeah, give it a shot. Give it a shot.
Another question, do most patients see better results with INTERSTIM than any other therapy?
I think it depends on the patient. Again, we tailor make the treatment for the patient, looking at the symptoms you're having, your quality of life goals, kind of your overall health picture. And I think that if we select, with your inputs, the correct intervention, then we're optimizing outcomes for you.
Dr. Watson's absolutely right on target. What he emphasized there is there are numbers, yes, X percentage of patients get better with this than this, but you're not a percentage. You're not 100 people, you're one person. And so one person needs one good treatment and that's all they need. So I would say, yeah, INTERSTIM overall probably has one of the highest success rates and longevity rates compared to medications and some of the others. But we all four have patients on all of the treatments that are doing great. The important thing is not giving up if one doesn't work and doing your very best to choose the right one. So what Dr. Watson said, we're mostly invested in each individual having a good outcome is the key.
Yeah. Would you talk a little bit about percent of success? There's a question just related to like some settings and things like that, like you're not 100%, but just kind of the overall success rate of the INTERSTIM therapy.
Okay, well, so I think 74% is what we call overall success. And you may ask, well, how do you gauge success? And success can be gauged as I'm 100% normal, or my symptoms are 50% better than they were. And so what you define success as may change what your numbers are. I would say, our goal is to get you to the best quality of life you can be. As I mentioned, some patients do hope for the moon. They hope for 100% success. And we do have patients who do get there, who literally are 100% better. We also have patients who say, I'm 70% better. I'm 80% better. I'm not like I was when I was 25, but man, I'm so much better than I was last week. That kind of quality of life improvement is still worthwhile. If that's as good as we can get, I'll take 50% compared to 0%. I want 100% for everybody. Okay. So, and when Dr. Watson and I do these procedures, we definitely take the time to make sure everything is optimized for each person. Were you're talking about leads?
No, just the 50% or better.
Oh, I see.
Improvement
Okay,
in
yeah,
symptom reduction, not.
That's what I consider a success, greater than 50% reduction in symptoms. And like Dr. Reynolds was saying, if you're not getting 100% improvement, most patients are still very happy because their quality of life has improved so much. And so if you go from let's say a 1 to a 5, 6, 7, 8, yeah, you're not at a 10, but your life is just so much better than it was before. So anyway, I consider greater than 50% reduction as a success.
Yeah.
But having said that, if I was doing an implant and in fact, Lindsay and I were doing one just yesterday. And no, this morning we were doing one. My goodness, where's my memory? This morning we were doing one, and on the x-ray, it looked good. It should have been in an ideal location, but we just weren't as happy with the response we were getting. So we replaced that thing twice. And on the x-ray, if you hadn't have been watching really close, you may not have been able to tell how imperceptibly different the change was. And yet we were finally really satisfied with our response. So now when that patient wakes up and comes back to see us in the clinic, if they are 75% better or 55% better, I will have no doubt in my mind that that is their max, because we took the time in the OR to be 100% happy. It was the best response that patient could have radiographically and in terms of their clinical response, how the muscles and the nerves work. So I think that's the key, is us being confident that we're getting the patient the best they can get with what we offer. So.
Can you see the battery under the skin? Does it protrude?
Not usually. If a patient is extremely thin, there's a possibility that it protrudes a little bit, but overall, no.
If the INTERSTIM is turned to a number higher, does it wear out the battery faster?
If there's high impedances.
No, like amplitude.
Yes, the answer is yes. So if you can run your device at a setting of 0.8 versus 2.8, yes, your battery will run out a little faster. And that's where it's important for us as the surgeons to do our absolute best. If we get that right next to the nerve, and I would say, Lindsay, correct me, you know better than I do, but I would say the majority of our patients run on very low
Very
settings,
low. Yep.
because we are very almost compulsive about getting that thing as close to the nerve as possible, where it's going to work, where you're going to have the maximum options in those contact points, and where you're going to be able to run low. So I would say of the implants I've done in the last 2 years here in Minnesota, the vast majority are running on very low settings.
And if that battery were to, die, which it eventually does, replacing the battery under 10 minutes.
Yep.
Under IV sedation, so very quick in and out. Best sleep of your life for 10 minutes, and you're good to go.
That's true.
Yeah.
One last
Exactly.
question. Good
Yep.
question, closing.
One last question here. What kind of comments do you get from patients that were hesitant at first? And then if they did go through with it, then after the fact?
Happiness.
Yeah, I don't know. What do you guys think? You see them in clinic and follow up a lot.
I have a lot of patients that say, oh my gosh, I only have to wear one pad a day now, or I can go to my granddaughter's soccer game without worrying where a bathroom is. And it's really satisfying for us to see
Yeah.
those results too.
I've had patients say, why didn't I do it sooner?
I would agree. That's the most common. So, and you should know when you come in, you're more likely to start off with Emily and Monica, who, believe it or not, may even be better than us, because they see you guys a lot and work this up a lot and talk to patients a lot about their symptoms. So this is absolutely true. After that first week test trial, you'll almost always see Emily and Monica to tell them how the test trial worked. And they'll get rid of that test lead, and they'll talk to you about your symptoms and get you set up for your final implant if you aren't already. So I would agree with those sentiments. Yeah,
Excellent.
Thanks for tuning in, everyone.
absolutely. Thanks for being here. And thanks to Medtronic for sponsoring this. And I think we all feel more confident we'll do it again.
Yeah.